Welcome to the Chapter 5 Clinical Application module. Today we are focusing on data-driven job matching in work-oriented neurorehabilitation, specifically utilizing the Occupational Information Network, ONET, alongside the DCAT-2 Occupational Task-Ability Profiler, or OTAP. This lesson will guide you through the process of translating your clinical measures into actionable occupational information. Occupational therapists often face what we call the clinical chasm. In the clinic, our evaluations rely on behavioral observation in a controlled environment, where we use the Employability Rating Scale, ERS, to assess accommodated performance. However, the 21st century economy is unforgiving. Employers prioritize speed, sustained multitasking, and the ability to manage unpredictable distractions. The fundamental question we must answer is, how do we translate clinical behavioral observations into the objective language of employers? The process begins with confirming core job demands, which we build into 3 layers during the initial interview. Layer 1 extracts the standard definition of the occupation from the ONET job summary. Layer 2 establishes the pre-injury competence rating, which serves as the client's historical performance baseline. Layer 3 is client validation, where we use the Structured Task Self-Appraisal, STSA, to help clarify the lived reality of their specific workplace. When presented with this data, a client might validate your findings by saying, "Yes, that's just what my boss is looking for, but I'm not sure I can deliver." To bridge this gap effectively, we rely on the standardized language of work provided by ONET, which offers a multidimensional view of 21st century labor markets. ONET links worker characteristics, like abilities and work styles, to occupation-specific information. This framework allows us to transition broad clinical observations. For example, the client did not recognize her errors in transcribing the telephone message, into specific, quantifiable metrics, such as the client's demonstrated ability with problem sensitivity resulted in a behaviorally anchored rating scale score of approximately 3.0. This is essential for providing empirical descriptions of progress required for rehabilitation planning, measurement of progress in therapy, and offering professional opinions in highly scrutinized forensic reporting. So how do we connect the clinic to the economy? We use the Occupational Task-Ability Profiler, OTAP, to guide our decision-making. The OTAP acts as a bridge, taking the Employability Rating Scale, ERS scores, time to completion, and error rates from your DCAT-2 evaluations, and mapping them directly to the ONET behaviorally anchored rating bar scores. OTAP provides a standardized, evidence-based estimate of the gap between a client's functional limitations and their specific job demands. The OTAP profiles performance across 9 of the 52 ONET abilities, divided into 3 domains. The first is psychomotor abilities, which covers wrist finger speed, finger dexterity, and manual dexterity. Second are integrated executive functions, encompassing perceptual speed, selective attention, and time sharing. And third are higher order cognitive abilities, which include 3 global abilities: visualization, oral comprehension, and problem sensitivity. The mechanics of the BAR scale are what make this translation from clinical observations to empirically defensible and quantified professional opinions. The scale ranges from 0 to 7 and uses behavioral anchors to quantify task difficulty. For instance, with regard to manual dexterity, a 1.0 equates to screwing a light bulb into a socket. A 4.0 equals packing oranges in crates as quickly as possible. And a 7.0 represents performing open heart surgery with surgical instruments. Each of the 52 abilities uses the same 7-point scale with different anchors, supplemented by 3 empirically derived benchmarks. Of course, this was just the starting point for the grading system that Edwin Fleischman and colleagues created and made available to the other members of the ONET development team in the 1990s. Since then, tens of thousands of work-related tasks and activities have been aggregated into relational databases within ONET to which the public has access. The bar scales approach, in the hands of properly trained and certified professionals such as yourselves, allows for precise apples-to-apples comparisons, translating qualitative observations into quantitative values anchored in real-world contexts. It's a very powerful professional position for work-oriented occupational therapists to hold. And it's important to recognize that this approach has been adopted throughout the world with only minor variations, because modern economies all use the same workplace technologies within which all of us are employed. The acute care nurse's job in California is almost exactly like the acute care nurse's job in South Korea, which is almost exactly like the acute care nurse's job in Germany. Let's apply this to a case study. Joanna Kim is an acute care nurse with 10 years of experience. Following a workplace fall on a staircase, she sustained a clavicle fracture, a cervical spine strain, and a concussive brain injury. Her current status is that she wants to return to work, and she requires a baseline evaluation to guide her work-oriented neurorehabilitation. Our goal is to determine the viability of returning to her customary employment using OTAP. First, we look at the unmoving target, the demands of an acute care nurse. These scores represent the minimally adequate level of ability necessary to safely and dependably perform 9 core tasks of our occupation that we can measure with the DCAT. In our clinical practices or in a forensic rehabilitation practice, we would address other ONET abilities of concern using a combination of standardized tests, work simulations, and review of evaluation reports from our colleagues in neuropsychology, speech pathology, physical therapy, or vocational evaluation. According to ONET, Joanna's job demands a 4.12 bar scale score in manual dexterity, a 4.12 in oral comprehension, and a very high 4.75 in problem sensitivity. Next, we map the functional gap by comparing Joanna's current demonstrated abilities, based on our observations of her performance on the DCAT, against these target job demands. We find that Joanna's OTAP assessment reveals significant shortfalls. For oral comprehension, her current score is 2.60 against a target of 4.12. For problem sensitivity, she scores a 3.30 against a target of 4.75. What do these deficits mean in a clinical and occupational context? Problem sensitivity is the ability to tell when something is wrong or likely to go wrong. For an acute care nurse, this carries a severe occupational risk as they must maintain high sensitivity to incipient threats to patient health. Joanna's score indicates an unsafe delay in recognizing impending crises. Similarly, her deficit in oral comprehension, understanding spoken words, presents a risk of critical medical errors due to an inability to accurately process rapid symptom reports from patients or families. And of course, this level of sensitivity to potential threats and her ability to understand what her patients, their families, and other colleagues are describing to her must be maintained throughout her shift at work, which is something Joanna and the entire rehabilitation team must take into account. As all of us know, a concussed brain often does not have the resilience and fatigue tolerance that the pre-injury brain enjoyed. This is where we start to get into the trade-off between a prolonged return to prior employment rehab goal versus a shorter-term adjustment of her career to fit within the parameters of Joanna's current abilities. Given these safety concerns, we must consider recommending to Joanna and her employer that they execute a strategic pivot. Rather than framing the DCAT assessment as a failure to return to her previous role, OTAP provides the objective data needed to begin to explore alternative careers within her hospital system. Our goal is to find a medically safe role, like a diagnostic medical sonographer, that leverages her 10 years of medical knowledge while accommodating her post-injury cognitive deficits. Using the Career Pivot Matrix, we can compare Joanna's current abilities side by side for both roles. While she falls critically short of the acute care nurse demands for problem sensitivity, 3.30 versus 4.75, and oral comprehension, 2.60 versus 4.12, the medical sonographer role requires much lower scores of 3.50 and 3.88 in those respective areas. This sonographer's path significantly lowers the cognitive burden, aligning the labor market demand with Joanna's post-injury cognitive reality. Although her DCAT evaluation doesn't tell the whole story, in this case, it is used to help Joanna adjust psychologically to a major change in her career path. It certainly won't be easy for her to leave the occupation she dreamed of and trained for several years, and that succeeded in over the last decade, but it may be the right choice for her at present. It's only for her to decide. At the very least, our test results have set the stage for Joanna to make a reasoned, rational choice about how to pursue the next chapter of her life. This OTAP data profile is a vital blueprint for aligning the interdisciplinary team. It provides the occupational therapist with data to design targeted work simulations that can help us identify the need for accommodations in her new occupation. It helps the neurologist correlate functional limitations with diagnostic testing and determine her future need for medical care. It allows the rehabilitation counselor to initiate specific vocational retraining early in the process and to develop a transitional return to work plan. Crucially, it allows Joanna and her family to actively participate in a transparent, realistic recovery plan. Joanna's fall at work and the injuries she sustained have led to an unwelcome departure from the trajectory of her life. But out of respect for Joanna and her independence, we can help her reestablish a productive and hopeful future. This highlights the dual power of data in work-oriented neurorehabilitation. On the one hand, we have empirical validation. It establishes legal and forensic baselines, focuses the clinical team, and directly maps abilities to ONET standards. On the other hand, it drives psychological adjustment. It reduces patient and family anxiety by replacing ambiguity and confusion with concrete targets. It transforms feelings of, "I can't do my job," into an actionable, "Here's the exact gap we are working to close." Ultimately, we must remember that work capacity evaluation is an act of care. For many of our clients, it's the most difficult and emotionally fraught experience of their lives. Objective job matching with good data is not just an administrative requirement. It is often a profound therapeutic intervention. It empowers patients to navigate the abyss of disability and confidently cross the bridge into their new reality. For those of us called to our rehabilitation professions, it's one of the most important, meaningful, and satisfying aspects of our work. It's a very full expression of our professional purpose in life.